Well, this evening we have Dr. James Luck, who has received his medical education at the University of Southern California, and he did his residency at the Orthopedic Hospital in LA. He's It's like he's received, several different awards. A few of the most recent ones is the Lifetime Achievement Award from the World Federation of Hemophilia and the Physician of the Year Award from the National Hemophilia Foundation. But he currently serves as Director of Orthopedics and Rehabilitation of the Orthopedic HTC for Children, and he's the author of numerous scientific articles, abstracts, and book chapters focusing on reconstructive orthopedic surgery. And he has served as visiting professor and has delivered over 200 lectures by invitation locally, nationally, and internationally. And you may have even noticed that he's going to be presenting at HFA in San Antonio in April. Currently, he has 5 big projects that he's working on, including a late infection of prosthetic joints in patients with hemophilia, total knee replacement in hemophilia patients with fused knees, a mouse model of arthrofibrosis resulting from recurrent hermethrosis, a patient-centered method of monitoring range of motion following total knee replacement, and the role of connective tissue growth factor in the development of arthrofibrosis in patients with hemophilia. So let me introduce Dr. James Luck. Thank you. Take it away.
Okay, thank you very much, and good afternoon, good evening to everybody. Some parts of this presentation, I think, are are probably of more interest to you than others and more germane, and we do have some time constraints, so I'll kind of move along. But if you have questions, please let us know and we'll deal with them at the end. We're going to talk about primarily elbow knee procedures, since those are the most common. I don't think we'll have time for the ankle. And we're going to spend a fair amount of time on infection, because infection is a crucial issue in orthopedic reconstructive surgery in patients with bleeding disorders, much more so than it is a general population, but it's a huge issue there as well. We're going to talk about what difference Hemlibra appears to have made, and we'll show some case presentations. So before Hemlibra, the literature on orthopedic procedures, at least major procedures in patients with bleeding disorders, wasn't super encouraging. It was okay, but there were a number of problems. Excessive bleeding resulting in having to go back to surgery. This one lower group where it says 7 major procedures, that was Dr. Solimento, who's an orthopedic surgeon with tremendous experience in hemophilia in Italy. 43% rate of infection, primarily secondary to excessive bleeding after the surgery and wound breakdown. In all surgeries, wound breakdown is critical, but if there happens to be an implant, like a knee replacement or some other kind of artificial joint underneath the wound, and the wound breaks down, that gets infected, that's a big deal. So our thought at that point was that for factor VIII deficient patients, or let me update that, our current philosophy for factor VIII deficient patients with smaller procedures, Hemlibra is fine with 7A. Larger procedures, Hemlibra with 7A or FIBA. And our experience that we're going to talk about tonight is 4 elbows, the radial head excision synovectomy, and I'll describe that procedure, 3 total knee replacements, and then a number of patients who have had infections that have been referred to us. And those all required extensive surgery. And that was actually a very good test of how effective our ability to deal with inhibitors was for orthopedic procedures. For factor IX deficiency, it's a little more complicated. We don't have Hemlibra. We have, for some of the patients, they can take 7A and FIBA, and that is reasonably effective. We don't yet know for sure about fitusiran, concizumab, these agents that block clot resorption. There's some issues there. They're still under investigation, but they may turn out to be significantly helpful. So we'll start with the elbow. And it is certainly one of the most common joints in hemophilia, and your survey at the start clearly showed that. Usually the patients start to have trouble in their 20s and 30s, sometimes younger. They have a history of recurrent bleeding, chronic synovitis, and progressive and limitation of motion of the elbow, both flexion, extension, and also, very importantly, rotation. So rotation of the elbow occurs through this half of the elbow. Can you see my arrow? You can see my pointer? Okay.
Yes, we can. We can.
The outer half, this half of the elbow. That's the part that rotates. The other part is a hinge joint. Okay. If that joint develops arthropathy, if it develops arthritis, and the cartilage degenerates and develops large bone spurs and what have you, it isn't round anymore. And it's very hard to rotate. So there's a mechanical restriction of motion that also causes impingement of the synovial membrane and bleeding and progressive arthropathy and pain. So the answer to that is actually fairly simple. That part of the elbow is expendable. You can take it out. You eliminate the impingement, you eliminate the impingement on synovium and bleeding, you eliminate the arthritis. You don't need that radial head. You do just fine without it, and it improves rotation, okay? So we reported on 42 of these procedures in 37 patients with a mean follow-up of 6 years. And the result in terms of cessation of bleeding was 97%. It was very good. A few patients required additional procedures, primarily for the ulnar nerve over here, where that nerve eventually became entrapped in scar tissue and required a procedure to free it up. That's a relatively small procedure. We did that just the other day. So let's look at range of motion. Now, the rotation, which is very important for eating, for personal hygiene, especially on the dominant side if you're right-handed, this was the range of motion before the surgery. Pronation, supination, total arc. That's the range of motion after the surgery. This is the range of motion at latest follow-up. So there was an improvement. It improved quite a lot. Not quite to normal, but significantly to benefit the patient. Now, this next slide is really critical. This is range of motion. This is flexion, extension. This is this motion. So here is extension, flexion, arc, total arc of motion. Pre-op, post-op, latest follow-up, no change. Now, since that study, we have developed some additional procedures, so we actually can increase that range of motion, but getting back flexion extensions extremely difficult, requires a lot of PT and more procedures than just the radial head excision. So in terms of pain relief of that procedure, this is just a picture of the surgery. That radial head, here's the neck of the radius. That radial head is easily 2 to 3 times the normal size. It's become very big, and it catches in the elbows. So the pain relief, this scale here, the Mayo Clinic elbow performance scale, 41.2 out of a possible 45, is excellent. This other scale, that was our study, this other scale by Adelar looked at visual analog, and the patients improved from 6.5 to 2.2, which is a significant improvement. Did all of their pain go away? No, because you still have the other half of the elbow. However, when we looked at the x-rays, we couldn't quite understand why they did that well, given the fact that the other half of the elbow still was arthritic. Look carefully at this x-ray. This is before the radial head excision. This is with the radial head excision. And look at the space that has been developed, but on the other half of the elbow, the ulna and the humerus, right? There is a big gap, a big space. That's why they were doing as well as they were doing. Now, this is a separate patient, had radial head excision in the past, and he has chronic synovitis of his elbow, okay? And that synovitis has caused resorption of the bone. So basically, it's almost like he did his own surgery. He took away a lot of that impingement. He has no impingement. He has no pain. He has full range of motion. He doesn't like the bogginess and bulging of his elbow, and eventually we'll do something about that. But it is very interesting. If you can do something to reopen the joint space, it can make a huge difference. Now, this is elbow replacement, which I think almost all of the orthopedic surgeons who do this work are not real enthusiastic about. There may be a couple, but there aren't very many. I know for a while they were being done. This is the outcome of the elbow replacement, and there are various pretty small series. Here's 7 patients, 5 elbows. Pre-op pain was severe. Post-op pain was in about half of the patients was quite good. And then 2 had mild and 1 had severe, and he required more surgery. I'll take you down to the last line because that's Ernst Bruner's study. And he had the largest series, 13 elbows and 9 patients. And you look at the number that had to be revised, 38%. And that's just in that period of time of the study. His mean follow-up was 9 years. Not too encouraging. So that's not something we are recommending. Since we've had hemophilia and we have done 4 elbows, 2 of them are patients that we're going to talk about who developed a systemic infection and got their elbow infected. That's a little different. But in those elbows, those surgeries where we did radial head excision synovectomy, we had no excessive bleeding after surgery, no wound breakdown, and no post-op infections. And that's what we want. So I personally am very impressed with how well those patients did on hemophilia combined with 7A as our usual routine. Okay, we'll move on to the knee. And as I think all of you appreciate, hemophilic arthropathy of the knee is much more severe than other types of arthritis in general. So here you see a patient where there are huge cysts that have developed in the bone, synovial cysts taking away a lot of the bone stock. Here's a patient with severe deformity. We'll show more of that type of case. So that makes the surgery not impossible. We have technique, we have implants to deal with that, but definitely more complex. It's classic knee replacement, resurfacing of the femur, resurfacing of the tibia. Still, we have the patient's ligaments, the patient's muscles, tendons, all that stays the same. And they actually have excellent results as long as we can keep them from having a wound breakdown or getting infection. This is a resurfacing of the kneecap you see right here. It has a plastic dome that articulates with that femoral component right there. So in our initial series, this goes back a ways. Dr. Silva and I reported on a large number of hemophilia patients having a knee replacement. At that point, 67% were HIV positive, 93% were severe. And one of the important features, which is no surprise to any of you here, is that the patients are relatively young. This is a young group for a knee replacement. Most of the time, knee replacements are in the 60s, 70s, even early 80s. This is a young group. This is because the disease has its onset in childhood. And that means these implants have to last a lot longer, hopefully. Look at our range of motion, pre-op, post-op, latest follow-up. Now, there was a broad range. Some of the patients got good range of motion. Some of the patients got poor range of motion. That's not the same amount of motion as you would expect in somebody with standard osteoarthritis or rheumatoid arthritis. They'll get 120 degrees. Now we are, again, doing some different procedures now that are gaining in motion. Plus the range of motion biofeedback that we're going to present at World Federation. All of these things help. So I think it definitely is better. but it's the arthrofibrosis. It's the fact that hemophilia patients, when they bleed into their joints, it stimulates scar tissue formation. They get very stiff. We can take the scar tissue out at surgery, but it tends to come back. So the results of those in terms of function, Knee Society functional score, 97% good and excellent results. There was one patient who got a poor result. He wore through his plastic interface here, and we wanted to revise his knee, but he didn't want any more surgery, so we counted him as a poor result. He was still happy. We weren't happy. This is the most important part of that study, and we're going to spend some time on this. It's like I said in the beginning, infection is a key. So look here, in terms of an endpoint, and this actually carries out to 20 years, survival of the implant, 96%. So the durability of the implants are fine. Now, if you go over here and you look at anybody that needed further surgery or had an implant removed, it drops down to 82% success, but nonetheless, 18% not success. So what was the cause of that? And the cause of that was infection. So since we have had Seam Libra, we have done 3 knee replacements in 2 patients. Both had long-standing, very severe arthrofibrosis. Both patients were essentially wheelchair dependent. And one patient, his kneecaps were completely dislocated for a long time because they kept bleeding and the tissues kept stretching and the kneecaps dislocated. And there wasn't anything anybody felt comfortable in doing because of a high level inhibitor. Then we had 2 separate patients who were referred to us with infection, and we'll talk about those as well. So if we look at the results of that, and that's big surgery. Excessive bleeding at surgery, none. Excessive bleeding post-op, none. Wound healing problems, actually there was one, and I'll talk about that. And post-op infection, none. Much better than what we've seen before in the normal knee replacement, much less the inhibitor patient. So here is a case, 29 years old, severe hemophilia A with a high-level inhibitor, arthropathy, early childhood, wheelchair dependent for over 10 years. And look at his kneecaps. They're out here in left field and completely dislocated. Well, that means he'd be very, very much unable to straighten his knees because the kneecap's not where it belongs. And that's where your muscles attach. A lot of deformity, marked angular deformity on both sides. The right knee was done in March and the left knee in July. A patelectomy, the patella was removed on the right because it could not be relocated. That requires a lateral release. And the patella was relocated. However, that required a lot of soft tissue procedures, and there was drainage that was repaired, fortunately, did not result in infection. That patient, amazingly, is now ambulatory without assistive devices. He quote, this was as of last night, says he has essentially no pain, maybe a little bit. His range of motion pre-op was 45 to 120. So he sat in the wheelchair, so he had good bending, wasn't able to straighten his knees. Now his range, he thinks it's about 0, but let's call it 5 to 135 bilateral. He said he can touch his butt with his heel. That's amazing. That's much better range of motion than most knee replacements, even in non-hemophilia patients. Now, a lot of this is the individual patient. Some patients are able to work harder on their range of motion than others, et cetera, and so forth. But that's a phenomenal result. We're very excited about that. Here's another patient, 50 years old, same story, severe hemophilia, high-level inhibitor, recurrent bleeding since childhood, wheelchair dependent, knee range of motion 10 to 80. So he had a little better range. But his kneecap, this is so typical of early onset, kneecap had shifted to the outside, and this kneecap had eroded down into the bone of the distal femur. And here's this cavity that it had created. I apologize if any of you are sensitive to surgical pictures. I should have probably warned you, like they do on the television. Okay, this is his post-op x-ray. So no unusual bleeding at surgery, no hemarthrosis, no post-op bleeding. He had difficulty gaining full extension, trying to get that knee out fully straight, and was somewhat painful with PT. It's probably now 20 degrees. He is fully ambulatory without crutches, and he was in a wheelchair before. So knee replacement for pain relief. And this is the general population. This is not just hemophilia patients, but it's excellent. It, as you can see, visual analog scale, less than 1, less than 1. This is knee society scale, higher the better. 50 is the maximum. Westberg study, 54 out of 58, 93%, no pain. Knee society, Chang study, 48, the knee society score. Excellent results. Now, there's a catch. There is pain postoperatively, and there is pain with rehab. And a lot hinges on how well the patient can tolerate that. We have a way to deal with the early post-op pain, which has been really helpful. So we inject a cocktail at the end of the case, a variety of medications, and more than you just see listed here. In this particular group, they used ropivacaine hydrochloride, which we use, ketorolac, which is a non-steroidal anti-inflammatory, epinephrine. We also use a depositing steroid. We also use an antibiotic. We also use some morphine. So that's all injected into the surgical site at the end of the surgery. And we're doing that routinely with a lot of our surgery. Ankles, knees, hip replacements in everybody, and it makes a huge difference. As you can see here, group A was the group that got the medication, and group B did not, and the amount of morphine they required after the surgery for the first 48 hours is hugely different. There's much lower pain at rest, lower pain with movement. They could start physical therapy early in the group that had this medication, and they were discharged earlier. So we're happy about that. That's making a big difference. So I'm going to move to, I think, what has been and hopefully won't continue to be a huge problem in patients with inhibitors. So these are patients who developed a blood-borne infection. Okay, we call it septicemia, and that can target any joints, all joints, whatever. So this is a 49-year-old severe hemophilia A patient on Hemlibra, thank heavens, with a high-level inhibitor. He's diabetic. He got an infected blister on his foot and got bacteria in his bloodstream, and it infected his right total knee, his left knee, which did not have a total knee, both ankles, both elbows, both shoulders, both the cervical and the lumbar spine with abscesses. Horrendous. And you know, scary terms just even of survival. So this was all treated with open washouts. In the case of the elbows, we took out the radial head, which was involved. In the ankles, we took out bone spurs abutting in the front. He was treated with Hemlibra and Novo 7, cultures of all areas, open debridement of multiple spinal abscesses, drains everywhere, IV antibiotics for 6 weeks, and then oral. No evident infection, required extensive rehab, but is now ambulatory without assisted devices, minimal blood loss at surgery, no post-op bleeding, no wound breakdown. This case and others like it are the acid test. This is somebody who had multiple joint surgeries, had a life-threatening infection, and it all worked out really well. So, you know, I'm very encouraged by this in terms of our ability to deal with high-level inhibitor patients effectively with orthopedic procedures. There's another one. 34 years old, hemophilia B, external venous catheter for a long time because he didn't have venous access. Those things are dangerous. They're not dangerous if you don't have an artificial joint. If you have an artificial joint, a knee replacement or some other artificial joint, that's a target. These things result in bacteria in the bloodstream. That bacteria, like you just saw, loves to go to an artificial joint because it can hide, because the artificial joint does not have any white blood cells. It does not have any antibodies. The bacteria can have a field day. So he came out to us with an infected total shoulder and an infected total knee. Severe arthrofibrosis in the opposite knee with a 90-degree flexion contracture. Multiple admissions for infected venous catheter with positive blood cultures. Chronic open draining sinuses, right knee, and we're talking about a very long period of time. So removal of the loose component of his shoulder, that's worked out well. Multiple INDs of the right knee, a right total knee, a right above knee amputation. This was his decision. And frankly, I think it was the right decision. We could have possibly salvaged his knee. We've done that before, but he said he'd had enough. And I don't blame him. And I think that was the right decision. And then open debridement of left knee arthrofibrosis. Multiple admissions for infected ports. Now, this is not to say that a hemophilia patient can't have a port. If they have a port, it ideally should be a buried port, and they use meticulous technique in prepping the area. So let's go back. Okay, he was covered with Nova-7 and FIBA. Fortunately, he does not have an allergy to FIBA, which some factor IX inhibitor patients have. We were able to use both. It worked out well. No excessive bleeding, no operative bleeding, no hemarthrosis, no unusual post-op bleeding. All wounds healed well without drainage. Now, I'd like you, well, I don't know how you're going to know this, but if you want to think to yourself what his hospital cost might be with multiple admissions, multiple procedures, et cetera, forth, inhibitor patient on Novo-7 FIBA, you know it's going to be high. Now, this is cost. This is not charges. This is cost. So $4.3 million, and that may be less than you were thinking. So anything we can do to prevent this, obviously tremendous benefit to the patient, but also benefit to the healthcare system. So most of us believe that in the future, the primary mode of failure of total joints may well be infection. Our total joints now are lasting much longer, thanks to greatly improved materials, some of which were developed in the biomechanics lab at our orthopedic hospital. This problem is more common in patients with hemophilia, a very serious complication, often requiring multiple surgeries in anybody who gets an infected total joint, and resulting in prolonged disability and a very high cost. So the key here is prevention. So if we go back to the earlier articles in the late 90s and right around 2000, a number of articles showed a huge rate of infected total joints. Ragney's study within the first 5 months, 26.9% infected total knees. Thomason's study, 20% infected total knees in patients with hemophilia. These patients were all HIV positive with CD4 counts under 200. All of his infections were HIV positive. Hicks also showed an infection rate of 18.5% primary, but revision surgery, 36%, all HIV positive. So what people said is, okay, the reason these people have a high rate of infection is because HIV effect on the immune system. And that is the result. Well, you look at later series, all in the 2000s, and the percentage vary, but the infection rate is still pretty high. So if we add that up, 556 knees, average follow-up 7.6 years, average rate of infection 8.6%, way above the general population, but there's no difference in the HIV positive, HIV negative patients. Sure, if a patient is really sick with AIDS, sure, they're higher risk. But in general, that's not the main risk factor. This is the numbers for the general population, non-hemophilia patients having a knee replacement or a hip replacement. 1% for hips, 1.5% for knees. Those are huge studies. Those are big database studies. So if it's not HIV, then what is it? Some of you, I think, know the answer to this because maybe we've talked about it or maybe you figured it out for yourself. We think it's IV self-infusion. And we started a study in 2005, ran it till 2017. And we trained the patients in good, meticulous sterile technique for IV self-infusion, our nurse practitioner did that. It doesn't like that when I move the mouse. Okay. They're reminded at every visit and of the importance of this and the fact that it may be the most important thing they can do to prevent infection. So over that period of time, we've done 53 joint replacements, 43 knees, 10 hips, with a mean follow-up of 8 years. We divided infection into 2 groups. Primary is the one we're most interested in, and that is an infection of unknown cause. So if you got it through your bloodstream from IV self-infusion, that would be a primary. Secondary infection were infections with a known cause. Dr. Goddard's series in England had one infection. It was in a patient that developed a tooth abscess, and that infected their joint replacement. So there was a big difference in HIV rate between the 2 studies, as you might imagine, about half as many in 2005 to 17, thanks heavens. Average CD4 counts, however, if anything, were a little lower in the second group, 5 under 200. Demographics were the same. But look at this. We didn't have any early infections in either group. Primary infection rate, the blood-borne infection rate, dropped from 16% to 0. There were 2 secondary infections. One patient who had a knee replacement, developed a pyoarthrosis of his elbow that spread to his knee. The other patient had a knee replacement and fell, opened up the incision, and that infected the knee. Those were known causes. For those 2 cases, the hospital charges, you can see, a lot less than our one patient who has all the problems with the IV lines, et cetera. So we believe the primary etiology of late infection, you have total joints in patients with hemophilia, is self-infusion. Careful patient instruction can make a big difference and save the patient a lot of grief, but also potentially save millions of dollars. And where possible, new therapeutics like Hemlibra or something else, not relying on IV self-infusion, should be utilized in total joint patients. So that brings us to the ankle, and I want to be sure we stay on time, and I was going to skip this. We've got about 12 minutes. Chris or Eric, do you want me to go through the ankle or skip the ankle?
I think you can go through the ankle if it's
It doesn't take
time to do
I
it.
think we're good on time.
Yeah.
It doesn't take very long. Okay, you're all very familiar with the fact. In some cases, the ankle is the first joint to be involved when little kids start running around. This classic X-ray, these abutting bone spurs that run into each other in the front of the ankle, classic hemophilia. I don't see them in any other type of arthritis. And the synovial membrane inside the joint gets caught in here, it gets pinched, and then it bleeds. Some of the patients develop an equinus deformity. That name comes from a horse because the way their foot is shaped, it's pointing down. And that is the result of either bleeds in the muscle or bleeds in the ankle. A lot of the patients can be managed non-operatively. They could be managed with braces, elastic support, stirrups, splints, injections. Harp was telling us earlier that he's, at this point, at least pretty happy with his injection of a lubricant of sorts. But the ones that have severe pain need surgery. Here's a picture of the actual x-rays. You can see this is the ankle joint itself, the tibia, the talus, small bone of the ankle. This is the ankle joint and the joint between the small bone, the talus, and the heel, the oscalcis. And this is involvement only of the oscalcis, which is the least common. Our recommended treatment is fusion of the joints that are involved. And that might just be the ankle joint, or the ankle and the subtalar joint, or just the subtalar joint. And the results of that, with a mean follow-up of 13 years, a mean age 37 years old, which is typical of this group, 57 arthrodeses, that's the largest reported series, with a fusion rate of 95%. At the time this study was done, none of the patients required any reoperation. The fusion rate was, even the ones that weren't solid with bony fusion were solid to where there was no motion there, and they did fine. I recently saw a patient who needed a reoperation because his bone just wasn't interested in healing, and hopefully it will this time. And we now understand that a lot better. That often is related to various molecular biological factors. Here's a video, which hopefully I can make work. Okay, so this is a patient, an ankle fusion patient. We'll do it again. Oopsie. I'd like to show it again if I can. Okay, watch closely. So you might think to yourself, well, which ankle is fused? Well, it's both ankles. But keep in mind that a patient with hemophilic arthropathy of their ankle doesn't move much anyway. There's barely any true ankle motion. So that doesn't change. And when a person has a fused ankle, they can walk normally. Because when you normally walk, you don't literally put your heel down and flop your foot in front of you. You put your heel down, your muscles in your leg tighten and hold your foot up in a neutral position, and then you stride forward. That propels you forward. So ankle fusion follow-up, pain post-op, our series, 75% had no pain, 25% had 3 out of 10. Eichler's series, 87.5% had no pain and 12.5% moderate. So really very good pain relief with that procedure. Ankle replacement, we don't recommend. I know it's done. I know it's done in hemophilia patients. I keep saying hemophilia patients with ankle replacements where the implant has worked loose or failed over a period of time. Keep in mind, the fusion lasts the rest of your life. Ankle replacements don't. So this is a Mayo Clinic series quite a few years ago. I think it's better now than it was then. But 36% required removal of the implant. Only 19% were good, 34% fair, 11% poor. So look here at especially at the bottom at Eckers. He has the largest series, and with the longest follow-up. And he had 2 of them required revision. 1 required a fusion, which is hard after an ankle replacement because you take away a bunch of bone. The post-op pain, initially post-op pain was good. 1.9 is not bad for visual analog scale. However, the survivorship of the implant goes down over time. And the radiographic analysis, this is Eckers again, showed that all implants, 100%, showed signs of component loosening and subsidence or migration. Well, that means that's going to require revision. It may not right at that time, but at some point, it's a painful situation when an implant loses its fixation. Okay, so that's the talk. That's my perspective on ankle fusions, but I wanted to leave you with a thought. So the estimated number of atoms in the universe are 10 to about the 80th power. it's estimated 78 to 82nd. It's about the 80th power. There are more possible, since you take your name from chess, there are more possible moves in chess than all the atoms in the universe. How about that? Now, the human brain has 40 billion neurons. Each has multiple synapses. There are 1 million billion synaptic connections, okay? Creating 10 to the millionth power circuits. Now let's go back to estimated atoms. That's 10 to the 80th power. This is 10 to the millionth power. And you carry that thing around between your shoulders. The other interesting fact is that the synapses that aren't being used disappear. Now, none of us are going to keep all of our synapses. They also disappear with aging, I'll have you know, but none of us are going to keep all of our synapses. But just think, if there was a way to keep more of them, or somehow to facilitate use of more synapses, think what the human brain would be able to do. And as we evolve, that's probably what will happen. So that's it. And Orthopedic Hospital today, the Orthopedic Institute for Children, you see this, you see our outpatient center, our inpatient center, our Orthopedic Hospital Research Center at UCLA, the Orthopedic Hospital Santa Monica UCLA Medical Center in Santa Monica, where we do all of our inpatient work. And this I'm especially happy about. This is the Orthopedic Hospital Medical Magnet High School. It's for inner city kids interested in careers in healthcare. It's on our downtown campus. So thank you very much. I'd be glad to answer any questions if there are some.
Thank you, Dr. Luck. It doesn't appear we have any in the chat box. I advise people to feel free to do that while you're speaking. Does anybody want to unmute their microphone and ask Dr. Luck any questions?
Yeah, Dr. Luck, this is Kevin Finkel. You did a radionucleotide synovectomy on my knee in the 90s. Yeah, I've been curious about getting either ankle fusion or a knee replacement, and wondered if you had any experience on inhibitor patients on Hemlibra using 7-FACT as a backup, new Factor 7A, 7A product.
Yeah, we just did one, and it worked out fine.
Okay.
Dr. Kwan could give you a little bit more detail on that, but it worked out fine. Was no problem.
Okay, and do you find during surgery are you having to use the backup, or do you do that routinely? The extra factor besides just the Hemlibra to cover the bleeding?
Yeah, so typically Dr. Kwan will start 7A or 7-FACT preoperatively, just before surgery, and continue it for about 10 days or so. And after that, depending on how the patient's doing, just Hemlibra.
All right, cool. And probably, so my right knee is contracted. So if I was going to do a right side ankle fusion, I would want to do the knee first, probably.
I think so. Yeah. I think it would, you'd get more bang for your buck if you did the knee first, if you like to look at it that way, and get that functional and rehabbed and then do the ankle. Okay. We have done both at the same time, but I think with an inhibitor patients at this point, we'd probably be smart to do one at a time.
Yeah.
Great question with the medications. Mm-hmm. Yep. Elvira, are you?
Yep.
Oh, there you go. Yeah.
Yeah, I have a quick, I guess a statement. My son has hemophilia B with inhibitors, and at age 12, he did have the synovectomy to the left knee and the left ankle at the same time. But we did so much extensive therapy and different kinds of machines because at that time, one of his legs was shorter than the other one. And so what helped us was that, and this is just, the start of the video games. And so his doctor suggested that he go on his stomach, so the leg can naturally go down. And then at night we put that brace on to extend his leg, and then extensive therapy. But I mean, it wasn't just at the hospital, but we had other additional homework that we had to do. So I think the sooner the better. And I just wish that we had done it way much sooner. But of course, that inhibitor and us just being new, and the doctor's not really, too much comfortable with it. But I'm glad that we were able to find Dr. Valentino, who was very aggressive and progressive in his thoughts. And we got that down pat. And then we just went on to the next elbows and, and other knees, etc. But it's just, now that he's 30, at that time he was 12, but now he's going to be 30. And now I worry about him as he's getting older and aging, and of course, arthritis. So will he eventually need fusions?
Well, it just depends, on how symptomatic the joints are. If he really works to keep his muscles strong, to maintain his range of motion, we recommend, quad strengthening, stationary bicycle, things like this. The more he can do of that, as long as it doesn't cause any bleeding, he can really prolong the length of time before he needs reconstructive surgery.
Great, thank you.
You're welcome. Good questions.
Mm-hmm.
I mentioned before that we are at World Federation, we're going to present a technique that we have developed. We're not the only ones, but we will be presenting a technique to give biofeedback on range of motion. So as the patient exercises, they can see in real time exactly what the range of motion is. So they know exactly where they're at and how hard to push and all that sort of stuff.
Dr. Luck, is World, is that piggybacked onto HFA, or is that scheduled out at a different time? Do you know?
World Federation is, I don't know. It's in Montreal. It is May 9th to 11th, I think.
Okay.
And does that conflict with something else?
No, I was just asking. I want to say that there was one year where World was in the same city, like right after maybe NHF, and I was just curious.
2016 in Orlando.
Okay.
Yeah.
Yep.
No, I don't think NHF will be at the same time this year.
Yeah, not this year. Not with HFA or NHF.
Okay. Yeah. Thanks for clarifying. Okay.
And speaking about world doctors, have you noticed that other doctors are doing much more other bigger things or different things versus here in the United States, such as Botox? A long time ago, I talked to a doctor from, I think, Argentina, and he was telling me that they were using Botox in the joints for the range of motions and things like that.
That's interesting. I hadn't heard about that, but there's no question that there are good hemophilia programs in Italy and South America and Scandinavia and England and France, etc. Spain, excellent. And they're doing a wide variety of things. Now, in some cases, they're doing things before we're doing them. And then we all get together at a meeting, we present our results, and then that helps. So I'd love to know more about that. If they happen to have published anything or done a study, if you could get your hands on a reference and send me the reference, I'll look it up.
All right, will do.
Thank you.
Botox, not just for beauty anymore.
Yeah, it seems like it's turning into the wonder drug for
a lot of things,
vocal cords, and
it's a little hard to imagine exactly why it would work in a joint, but you don't ever want to criticize something out of hand until you know more information. It may be that it's useful somehow. I don't know. They're definitely using protein or platelet-rich plasma, PRP, into the joints. Italy's doing that with some reasonably good results. A variety of things.
Dr. Luck, I had a question with that video, the patient you showed with the fused ankles. That's impressive. I was asking myself the same question: which ankle was it?
I couldn't figure it out.
Is Is that a typical result as far as, I guess I'm just curious, like what his pre-op range of motion was? Was it at 90 before, or was it worse, or it was?
No, it wasn't worse. It's
Okay.
basically the same. Almost all of the patients that come to ankle fusion have no motion in the true ankle joint. Where they have motion is the joints in front of the ankle. There are two levels of joints in front of the ankle, midfoot joints we call them. And if the ankle is stiff, they still move. And that is one of the reasons the patients with ankle fusions walk so well, because they can use those joints.
Okay. So
It also helps if you're, driving, operating the accelerator of a car. If it's your right leg, you need a little bit of motion there. And those joints do very well.
So if a patient has a range of motion that's greater than 90, then they could very well expect to get 90 out of the use of those extra joints after they get infusion and
probably not. If the ankle isn't moving, those joints are responsible for 20 or 30 degrees, but the normal ankle motion with normal ankles is about 20 degrees of extension and about 40 degrees of flexion, net 60 degrees of the true ankle joint. These other joints move about 20 or 30 degrees. So the ankle fusion, well, those patients don't have ankle motion anyway, but basically then they just have what that midfoot motion is, and that's what you saw in the picture.
Yeah, but the difference is no pain, right? No arthritic pain.
No pain.
Or greatly reduced pain.
And durability. It's not going to break down. And no pain even with quite a lot of activity. In other words, it isn't something that's going to get tired or get painful at the end of the day, this type of thing, which the ankle replacements can do.
Yeah. That's my biggest, both of my ankles are very arthritic and have been getting progressively more so over the years. And especially if I'm up on them, during the day, the next day I'll really feel it. So that's got me contemplating some fusions.
Can patients get bleeds from fused ankles still?
No. You need motion to bleed.
Yeah, which is probably why I haven't had an ankle bleed for decades. I had a lot right. As a kid, but haven't had one. It's just the arthritis.
Yeah.
Any other questions for Dr. Luck?
Okay, well, thank you all very much. Hope you have a wonderful evening and hope things go well for you.